Hi, I'm Ken Cutbush, a shoulder surgeon working in Brisbane. I'd like to take you through the planning that I go through for a reverse shoulder replacement. So this is preparing for the surgery for the reverse shoulder replacement. What we do for a lot of patients is create a patient-specific instrumentation, a guide that we use in theatre to make sure that we get the prosthesis in exactly the position that I've planned to put it into. I'll take you through what I mean by that. So this patient here has severe osteoarthritis. You can see a big osteophyte down here. There's joint space narrowing. What keeps the joint apart is the cartilage. There's cartilage on both sides of the joint. So a normal joint will have quite a gap between the two bones. A joint like this, where it's becoming quite arthritic, the actual gap between the bone of the humerus and the bone of the glenoid or the socket side, the gap narrows because the cartilage is gone. So you can see that here. You can see what we call sclerosis. That bone is quite sclerotic or hard. That's another feature of the osteoarthritis. And it's actually starting to flatten off too, because what you've got is bone-to-bone contact and the humeral head is rubbing into that glenoid and it's flattening off. And that's part of the process with the osteophyte or spur as well. You can see there's a little cystic change in there. And the other thing you will see with some patients is a little loose body. You get a feeling that might be a little loose body down there as well. Little bits of bone break off, they take on a life of their own and start growing inside the joint. So this is severe osteoarthritis. If we look at the MRI scan, we see the same features. We see this large osteophyte down the bottom. You see a bit of fluid. The white is fluid. And you can see what I mean about the lack of cartilage. We go from bone to white, which is fluid, to bone again. There's just no cartilage anywhere in that joint at all. So this is the humerus. We can see the humeral head here. This is the glenoid or the socket of the shoulder, and the shoulder blade or scapula is this here. You can see that's acromion. That's part of your shoulder blade. That's the acromioclavicular joint, the AC joint, and that's the end of the clavicle there. You can see the outline of the skin, and this is the deltoid muscle down here. Deltoid is very important in a reverse shoulder replacement because it's what powers the reverse after the operation. It's the prime mover of the shoulder at any time, but particularly after a reverse has been performed, it's the prime mover of the reverse shoulder replacement, even more important. You can see here the rotator cuff on the top of the shoulder. So we have 4 rotator cuff muscles, 2 at the back, teres minor, then infraspinatus a little bit higher up. Across the top is supraspinatus, and then at the front of the shoulder is the subscapularis. They're the 4 rotator cuff tendons. And this here is supraspinatus. You can see the spindle shape of that muscle there, forming tendon. You can see the tendon starting to form within the muscle, the little black streaks there. And then this is the tendon proper itself coming across the top of where there used to be cartilage and joining onto the bone over here. And you see it's not in particularly good condition, but it is intact in this patient. The AC joint's worn out, you can't see a gap there, but that's what it is in most patients. You don't necessarily need your AC joint removed just because it's a bit arthritic there. It's only if it's causing pain that I would remove it. So that's what we see preoperatively. If we go to the MRI scan and look at the transverse or axial view, that's this one here. What we see here, so you see the lungs here, you see there's a rib there. This is the shoulder blade. This patient's lying on his back, so that's the back of the patient's back, and that's the front of the shoulder. This is the back of the shoulder, that's the front of the shoulder. You can see, so this here is rotator cuff at the back of the shoulder. This is the deltoid here. You can see the outline of the skin. This is rotator cuff at the front of the shoulder here. You can see the little biceps tendon there. So the bicep tendon sits in that groove there. You see the white around that bicep tendon? Well, that's fluid around it, and you see fluid in the joint as well. That's a lot more fluid than you would normally have, and that indicates the shoulder's sore and it's a bit inflamed and so on. And so you've got fluid there. And again, you haven't got cartilage between the 2 bone surfaces. You go bone, white, which is fluid, and then bone again. And the other feature on this scan is if you draw a line up that shoulder blade, it's going through the front of the humeral head. Before this shoulder became arthritic, that humeral head would have been centered within the glenoid. The arthritic process typically causes the shoulder to sublux posteriorly, and then you get this situation where the back of the shoulder wears more than the front of the shoulder, and that's happened here. The glenoid or the socket here at the back of the shoulder has worn more, and it progressively burrows into the back of the shoulder there. It will often create a double concavity. So that's what we're seeing on the x-rays and the MRI scan preoperatively. What we're going to go to next is look at the CT scanning, and we'll look specifically at the planning software or for one of the companies that I use and how I plan a shoulder replacement with that planning software. So This is the patient that we were looking at with these x-rays, the severe glenohumeral arthritis. And we're now looking at the CT scan. So this is the CT scan. And you can see we get some information from the planning software. The yellow line here is the axis of the shoulder blade. The blue line is the articular surface. What we like to see is the blue line perpendicular to the yellow line, or square to the yellow line, like that. This one is tipped backwards. We call that retroversion, which you can see down there. And this one's retroverted 11 degrees. Now 11 degrees is just outside normal. The normal range is 0 to 10 degrees of retroversion. More than 10 degrees is a problem. So that's one of the things we're seeing with this shoulder. The inclination is interesting. This patient is inclined 2 degrees. That doesn't have a big bearing on the shoulder positioning and what we do. It has some. But the big thing to show you is this here. So this is a graphical representation of how centered the humeral head is. And it should be half blue, half green. This patient, before he became arthritic, would have had a shoulder that was half blue, half green, would have been centered. It's usually line ball centered right on 50%. And you can see his shoulder is mainly green with a little bit of blue. It's 74% sublux posteriorly, which is quite a lot. And that's one of the reasons why the shoulder doesn't work very well for him, and it certainly contributes to pain. It's why the shoulder, is starting to become an increasing problem for him. So they're parameters that we get from the CT scan and from the planning software, and we look at. You can see, of course, the spurs, a big osteophyte down the bottom, out the front as well, and out the back also. So this is the back of the shoulder, and that's the front of the shoulder. This here, the back of the shoulder, is where the green is. The front of the shoulder is the blue side with the coracoid process there. Okay, so we look then at the socket side first. So remember, it's a reverse, so instead of a socket, we put a ball on this side, and you see that here. So there are different ways to do this, and it depends on surgeon philosophy. My philosophy is generally, in most cases, I will do what we call a bi-RSA, and what that means is there's a bone graft going underneath the base plate. What we want to do is move the ball, the glenosphere we call it the glenosphere, we want to move that away from the shoulder blade. The more we move it away from the shoulder blade, the more the range of motion improves, and also the more the strength of your rotator cuff of internal external rotation improves as well. Improves the strength of the shoulder post-operatively. But you can go too far. So there's sort of like a sweet spot that we want to aim for. That bone graft comes from the humeral head, so I'll just show you where that comes from. So what we're going to do in the surgery is we're going to take off that humeral head, we're going to take the ball off, and we're going to put a socket there instead. So before we take that ball off, we're going to take a structural graft out of it, and that structural graft will then go here. And you see we've got it on these panels here, on the axial and the coronal slices, we've got the bone graft in there, and you can see the bone graft in here represented there. And that bone graft is a little ring or a little donut of bone, a structural bone graft, which we'll take out of the humeral head here. So once that's taken off, you can see the stem that's going down down the humerus. You'll see, make it a little bit transparent, you can see the stem there. We're going to shorter and shorter stems with the reverse shoulder replacements. These stems used to be quite long. And on the humeral side, we then put a socket, so you can see that socket there. Well, of course, we'll take off the spurs and osteophytes, the bone spurs there, and then that all comes together like this. You can see this program is quite clever. It's checking the range of motion for us, and actually calculates out range of motion parameters just here in this little box here. And there's something that I look at very carefully. The other thing I look at is the amount of lateralization, how much we pull that glenosphere away from the socket, away from the scapula, and how much distalization we give you. A reverse will generally be about 2.5 to 3.5 centimeters longer in that arm because of the very nature of the reverse shoulder replacement, the actual mechanics of it. The reverses are always, the arm is lengthened on that side, and for most of the systems it's around that 2.5 to 3.5 centimeters. It certainly is for me. So you can see that's how it goes together. The ball and the socket are reversed, which is why it's called a reverse shoulder replacement. That's where the name comes from. So once I've got these parameters, the positioning, the main part of that positioning is on the ball side, the glenosphere side. There are some changes to do on the humeral side. But once I've got that in the position that optimizes the range of motion, and this range of motion isn't necessarily the range of motion you'll get post-operatively with your physio, but if we don't have it built in at this point now, you won't be able to get it with the physiotherapist, because this range of motion is the prosthesis to bone or bone to bone contact, and it's an absolute variable. So we have to build it into the planning at this stage so that it's there when we do your operation, because if we don't have it here, you will not be able to get it afterwards with your physiotherapy following surgery. So it's very important, the planning. So how do we get that all then to sit like that once we've got that planning done? How do I achieve that in theatre? Well, what we do is get a guide made up. Well, there's two ways. We can either navigate it or get the guide, and what I'm showing you is the PSI guide, the patient-specific guide. Now this, you can see here, that's a little guide that clips onto your socket at the time of surgery, and it gets me down that red line, which is the axis of the shoulder blade. It's the same as that yellow line we looked at just a little bit earlier on. So the guide is put on, and then it's taken off once I've got the position set, and then you'll see the glenosphere and the bone graft all will then go in that position, and that's how that works. Now I'll just show you some of the planning that we go through and some of the changes. So if you look at this, it's possible to position this within 0.5 millimeter increments, either inferiorly, posteriorly, or anteriorly. We can tip it as well, we can angulate it. So one of the things what I'll do is put it into a position. We'll just save this as option 1 in terms of the range of motion that we've got there, and then we'll change the position of the glenoid, and I'll show you how it changes. So what we're going to do is put the whole construct quite a lot higher up, and so this is where you don't want your shoulder put, and I'll just show all I've done is lifted it up the surface of the socket by a matter of a few millimeters. And then if we then add that, we'll call that option 2, and then we'll pull it up. What you're going to see is a big difference in range of motion, particularly with extension. We've gone from 120 degrees of extension to 15 degrees of extension. And that's what I'm talking about, that 15 degrees of extension. For internal rotation, extension is an extremely important part of it. So if we limit it to 15 degrees, you're really not going to get that. Internal rotation has gone from 53 degrees to 20 degrees, so that's internal rotation like this. So we're going to suddenly lock that shoulder. You'll find that the shoulder starts to lock up if the shoulder was put into that position. So that's why we don't want to do that. So instead, what we want to do is bring it back down to where it was. At the same time, we don't want to go too far. And this depends on the size of the skeleton. A small skeleton, I will normally distalize the prosthesis maybe 2.5 centimeters. A big skeleton, maybe more like 3.5 centimeters. So that's a run through the planning that I do for the shoulder and the planning that I do to get a patient-specific guide, which is one of the ways that I can navigate to get the prosthesis put in the best possible position to get the best possible range of motion for you. So I hope that that helps make a little bit of sense of the planning that goes into preparing for your shoulder replacement.